Hello everyone. So today we will be discussing about medical diseases and infections in pregnancy. Okay. So without a further ado, let's start the topic. The importance of this topic is yes, questions do come from this topic, and they can also cost 1 marks. Okay, as we are expecting quite a average or difficult exam this time, so we have to complete each and every topic. Here in this video I have very beautifully explained all the concept. It will be easy for you to remember, and it will be easy for you to grab that 1 mark also. Okay, so let's start it. Starting first with the hepatitis B. Okay, vertical transmission. Vertical transmission is what transmission which occur from the mother to the fetus. That is very important to us. That is very important to mother. That is very important to doctor. Okay, so the transmission of hepatitis B. If mother is having hepatitis B, and the transmission of the hepatitis B from mother to child is maximum at or around the birth. Okay, it is by the mixing of maternal and genital secretions. Okay, so by that means the transmission of hepatitis B is maximum at or around the birth. Okay, so they can ask you is maximum at third trimester, first trimester, second trimester, so you have to say third trimester, and more specifically intrapartum or peripartum. Okay, there is a one word meaning peripartum. Peripartum is just after the removal of the placenta. Okay, just at the time of placenta removal. It is not in intrapartum. Intrapartum is associated with fetal delivery, so this is peripartum. Peripartum means the time around the placental delivery. Okay, prevention of infection. How we can prevent the infection? Now we know that the infection will be transmitted in the third trimester. How we are going to prevent that infection in the newborn? Okay, so we will do the active and passive immunization both. Why passive? Because we know that the most likely the transmission has occurred in the perinatal period. So to kill that antigens, that hepatitis B antigens which has entered the child, we have to give passive immunization. In the same way, we give an anti-D, right? We give anti-D when RH positive fetal antigens come into the mother blood. To stop the sensitization, we give NTD. And similarly here, we will give the passive immunization, that is immunoglobulin G. Okay, immunoglobulin G is a passive immunization to kill the hepatitis antigen transmitted at the time of delivery. As you know, we are here giving the in the passive immunization we give here immunoglobulin G, and we want to kill the antigens, hepatitis B antigens that have transmitted during the delivery. Okay, then we have to give it within 12 hours. If we will not give it within 12 hours, then they will not then this passive immunoglobulin G, passive immunization immunoglobulin G will not act. Okay, so here I would like to say you that please, if you want to give passive immunization, then please give it within 12 hours of the delivery, not to delay it. Okay, that is what the question was asked once. Okay, and the active immunization is that we will give some hepatitis B antigen as we give in all the newborn child, so that the newborn child gets a strong and systematic immunity for the hepatitis B. Okay, that is what is the difference between the infection and active immunity, right, and vaccination. Because there in the vaccination we give very less dose, so the person gets the immunity also and don't get the symptoms also. So here also we will give the active vaccine also, we will give the hepatitis B vaccine also, and we will give the immunoglobulin G also. This is a highly expected question. If the examiner would like to give from the hepatitis infections in pregnancies, this is highly expected. We have not to miss the vaccine also, and we have to give the immunoglobulin G both. Okay, as the answer to it is because the transmission most commonly occurs at or around the birth. Okay, So okay, so let's go to the next slide. Now first, there is one question they ask is that high risk of maternal mortality. As you all know, maternal mortality is quite a significant important topic. Okay, and it's really very close to the heart of us obstetricians. So maximum risk of maternal mortality out of all the five hepatitis infection is hepatitis E. Okay, if the mother has hepatitis E, then it is for sure around 90% of the mothers who have hepatitis E during the pregnancy, not as such. Okay, during the pregnancy, if the mother has hepatitis E, it is 90% sure, even more than 90%, that the mother will die. I, in my whole career of 12 years, I had two patients of hepatitis E. Yes, they both expired. Okay, so it is there that once the patient has hepatitis E during the pregnancy, the patient has very high chances of maternal mortality. Okay, breastfeeding is not contraindicated if the patient has hepatitis B and hepatitis C. Again, I'm telling you, mm, please don't stop the patient from breastfeeding. Okay, all these things are still being continued. They stop in India, they stop the patients from breastfeeding, but please, it is very very harmful for the fetus if you stop the fetus from the breastfeeding. Okay, cholestasis of pregnancies is another liver problem. Okay, that is also there in the in your syllabus. So what happens in cholestasis? Coli means something related to bile, and stasis means ruk jana. Okay, to get stopped, or accumulation of bile acids in the liver and subsequent accumulation in the plasma. So there is in the liver the bile acid, they get accumulated. Okay, and then because of the subsequent accumulation in the plasma, the patient who has this cholestasis of pregnancy, it suffers from pruritus and jaundice. Okay, pruritus and jaundice. Do you got my concept? So the patient who has cholestasis of pregnancy, due to the accumulation of the bile acid, patient gets pruritus and jaundice subsequently. Okay, so this is very important feature, that the patient of cholestasis of pregnancy has pruritus. What is pruritus? The whole body starts getting itching in the whole body. This itching is too much. As you all know, I'm from Punjab. In Punjab, there is a lot of overeating habits we have. So that is why we are more prone to cholestasis of pregnancy. We the patients of Punjab are more prone to cholestasis of pregnancy. So yeah, I always say ki here every third patient I get is cholestasis of pregnancy. Okay, so patient gets so such a severe pruritus that patient can't sleep. Okay, keeps on itching the whole night. Okay, so yes, this is there, and due to that bile acid accumulation, there is also the jaundice. First of all, this is most common in the last trimester. Okay, this problem is most common in the last trimester. It's really occur in the first or second trimester, and bilirubin not exceed 5 milligram. Not exceed more than 5 milligram. So you will never see the jaundice value more than 5. Okay, and SGOT and SGPT, they don't exceed 500. Okay, so you know that this level of SGOT SGPT also in the help. So how you will differentiate it if there are increased liver enzyme in the help and increased liver enzymes in the cholestasis of pregnancy? First of all, the cholestasis patient will come with the cholestasis patient will come with pruritus, and the help patient will come with uh, increased BP. Okay, sometimes in 10 to 15% patient don't come with increased BP. In that condition, the patient, you will see that the blood parameters, there will be hemolysis is okay, and there will be decreased platelet. Okay, so mainly due to cholestasis of pregnancy, mother only gets itching, no other problem to mother, but the fetus get a lot of problem due to this cholestasis of pregnancy, like meconium stain lichens, IUGR, IUD. So to prevent this IUD, the delivery is done at 38 weeks. Okay, and the treatment, what we can give to the mother to get relief is ursodeoxycholic acid. Okay, ursodeoxycholic acid has a very good result. Okay, we can take the pregnancy up to 38 weeks with the help of the ursodeoxycholic acid, and other drugs which we can give is antihistamine, cholestyramine, and corticosteroid, but best is ursodeoxycholic acid. Ursodeoxycholic acid, another name is ursodiol. Okay, it's ursidiol. Okay, so let's go to the another problem, HIV in pregnancies. This is very 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 favorite of examiner. Okay, so first let's start. Patient came to you. You all will always do the HIV. We always do the HIV test. Okay, so the if HIV is diagnosed, then ART has to be started and it has to be continued lifelong. Okay, there are two therapies in which the pregnancy don't interfere. One is ART and the another is TB. So if the TB and if the HIV is diagnosed during the pregnancy, we have to start the treatment as do in a non-pregnant patient. Okay, so ART and ATT, they don't interfere with pregnancy, they don't cause, rather giving this helps the patient and helps the fetus both. Okay, so once the patient is diagnosed with HIV, then the ART has to be started and it has to be continued lifelong. Okay, you all know that. And yes, ATT has a specific time. Okay, and the ATT, we will start the, if the patient is diagnosed with TB, then we will start the ATT in pregnancy. Even in the first trimester, we can start. That is what the question they ask. Can we start in first, second, or third? We can start in the first. It does not interfere. Only streptomycin is teratogenic, so it is contraindicated. Okay, so we don't give streptomycin. We have other drugs for in the ATT also, so we do manage with that. Okay, now TB, the tuberculosis, it flares in puerperium. Okay, as you all know, patient after the delivery is having high TLC and low immunity after the delivery. So bit low, not much low, but low. So TB flare in puerperium as compared to the whole antenatal period. Okay, in ART, in ART, some drugs they are not given to the patients. Like I said, in ATT we don't give streptomycin. Similarly, in the ART we don't give some drugs like tenofovir alafenamide. Okay, please be cautious. I'm not saying tenofovir. I'm saying tenofovir alafenamide. That is denoted by TAF. It is, we can't give this drug during the pregnancy. Okay, tenofovir alafenamide, it is denoted by TAF. Okay, next is what all that we study. TAF, tenofovir alafenamide, is not given. Then what is given? Tenofovir. Okay, tenofovir, TDF, and then 3TC, 3TC, that is lamivudine. They are preferred along with efavirenz, because you know that in the case of the ATT, first line therapy which we give is 2 NRTI and 1 NNRTI, isn't it? So 2 NRTI which we use is tenofovir and lamivudine. The another name for tenofovir is TDF, and 3TC is another name for lamivudine. And along with it, 1 NNRTI which we give is efavirenz. Okay, now let us see whether HIV is transmitted vertically or not. Usually the fetus is not affected. So okay, so don't frighten your patients that you have and your fetus will transmit. Rather relax them that usually the HIV does not get transmitted to the fetus. Okay, 80% of the chances it does not get transmitted to the fetus. Okay, transmission occurs mostly at the labor. At the time of the labor, the transmission occurs. Okay, if it occurs, usually transmission does not occur. If it occurs, it usually occurs at the time of the labor. Elective cesarean decreases the risk. Okay, as in herpes, the risk is zero if we do cesarean, but in HIV, the risk is decreased a lot. So always prefer the HIV for the HIV patient to do cesarean. Okay, because the risk, vertical transmission risk is quite less in the case of cesarean. Viral load of mother is the major determinant. What is the viral load? CD4 count of the mother, that is the major determinant. Both are important. Viral load and CD4 count both are important, but among them the viral load is more important. Okay, so viral load of the mother is the major determinant. Okay, so are you able to get these things? More will be the virus in the blood of the mother, more will be transmitted to the fetus. Okay, so now let us see what we can, what ART we can give to the fetus so that its transmission risk decreases, the disease risk of HIV decreases. You will be shocked to know that if we give ART nevirapine to the fetus, then there only 1 to 2% of the child they get HIV. Rest all are saved. Okay, so usually in India, 30-35% of the fetus were getting affected from the mothers of HIV. 65% were getting saved. But when we started giving nevirapine to the fetus, only 1 to 2% child were having it. So yes, question to banta hai fir nevirapine pe. Okay, so they ask you what you give to the fetus to decrease the risk of transmission, and it's such high decrease, only 1 to 2% of the fetus then they get. So if exclusively replacement feeding, because in HIV in the developed countries, we don't allow the patient to breastfeed to decrease the risk of transmission, but in our country we allow. So if the patient is exclusively on the replacement feeding, okay, if not giving, the mother is exclusively giving the replacement feeding, ऐसे नहीं है कि बीच बीच में lactate करवा लेगी, no, not that, exclusively replacement feeding, then nevirapine is given from the birth up till 4 weeks. And if the breastfeeding is being given intermittently or exclusive breastfeeding is given, then nevirapine is given up from the birth to 6 weeks. Okay, I hope you get it. Okay, now there's another infections which are quite commonly asked, that is hydrops fetalis. You all know hydrops fetalis is of two type, immune and non-immune. Immune is the one which occurs due to Rh negative incompatibility, that and non-immune are the other causes. So immune is less common than the non-immune. Okay, because you all know that negative blood group is found only in 3 to 5% of the population, so how immune will be common, right? And you will see there's a list of diseases in the causes in the non-immune, so obviously non-immune will be more common. So let us see what are the other causes of non-immune. The congenital heart diseases, the congenital heart diseases will lead to the heart failure, and the baby fetus will suffer from hydrops will fetalis. Okay, so congenital heart disease is the most common cause of hydrops fetalis. Then the aneuploidy, most commonly Turner syndrome patients. Turner syndrome patients is suffer from aneuploidies. Third is the maternal infection. Okay, most common is parvovirus B19 infection. You all know this. I'm very happy you all do it correct. Okay, why these infections they cause hydrops fetalis? Because they affect the erythroid progenitor cells. Okay, these are the cells which give birth to the RBCs. So that is why, because there is anemia, because the erythroid progenitor cells they get infected, so the fetus suffers from anemia and subsequently hydrops fetalis. So most common is the parvovirus B19. You all know torch infection. So out of the torch, everyone causes the hydrops fetalis except rubella. Okay, rubella does not cause the hydrops vitalis. Toxoplasma causes, cytomegalovirus causes, herpes causes. Okay, so all causes except rubella. Recently in the INI set they asked them other causes of no, fetal hydrops, and they were given a list of infection. So there. HIV was not causing. Okay, so I will just tell you that please remember all these causes, because lastly only it was asked in INSET that you all know most common is parvovirus B19, and it's very easy to learn all the torch infection causes except rubella. Okay, okay. In that question of INSET, the answer was HIV. Okay, so microcephaly is another thing which they ask. Microcephaly is caused by Zika virus, because in the 2015 and 2016 it caused a lot of epidemic. So you should know that Zika virus is the one which has created hell during 2015 and 2016. The fetus born during that time all were suffering from microcephaly, and in the torch all the infections causes microcephaly. Toxoplasma causes, rubella causes, cytomegalovirus causes, herpes virus causes. Okay, so all the infection of the torch causes microcephaly, but all the infection of the torch does not cause hydrops vitalis. Only rubella does not cause, rest all cause. Okay. Heart diseases in the pregnancy, let's do this also. This is also a very short topic. Most common heart diseases found in pregnancy is a mitral stenosis. Okay, and as you all know, rheumatic heart disease is quite common, so mitral stenosis is quite common in the pregnancy. NOP is the mnemonic how we predict the heart failure in the patients of the heart diseases in pregnancy, and stand for NYHA grade 3 and 4. So any diseases if it is having grade 3 and 4 of NYHA grading, so then yes, so any severe heart diseases will, yes, the patient will get into heart failure. Okay, so they say that it is not that only few diseases will go. Any diseases if it is having a severe grading, then the patient, pregnant patient, will go into the heart failure. Okay, next is O stand for obstructive lesion. If mitral stenosis is less than 2, and aortic stenosis area is less than 1.5, then yes, the chances of heart failure increases. Okay, and as you all know, now mitral stenosis is the most common heart diseases. So if the mitral stenosis area is less than 2, then yes, the chances of heart failure are there. Okay, P stands for prior cardiac failure, arrhythmia, or stroke. So if there are prior episodes of cardiac failure, arrhythmia, and stroke, then yes, the chances of heart failure are much more. E stands for ejection fraction. If ejection fraction is less than 40%, yes, then the causes of heart failure are there. Okay, next is heart diseases in pregnancy. There are some diseases in which the pregnancy is contraindicated, because yes, they are severe diseases and patient will die of. So the mother will die of. So the pregnancy is contraindicated. So let's see what are those diseases. Eisenmenger syndrome, primary pulmonary hypertension, Marfan plus aortic root involvement, uncorrected aortic coarctation, any diseases, NYHA 3 and 4 as already we studied. So what are the others? Usually the question is asked on the first two, Eisenmenger syndrome and primary pulmonary hypertension. Okay, heart diseases in which the pregnancy is contraindicated because the mother dies. So that is Eisenmenger syndrome and primary pulmonary hypertension, that is usually asked. But you can also learn the other three. They are also easy. Marfan plus aortic root and uncorrected aortic coarctation. Okay. So let us study how we are going to manage the patients. We should know what are the what is the period in which the heart failure will occur. Yes, it corresponds directly to the period in which there is maximum cardiac output, because heart will be at a great load. Already the heart is having diseases, and if the cardiac output will increase, then the heart will of course suffer. So immediate postpartum is the most risky period, because at that time cardiac output shoots much high. Then next risky, then the immediate postpartum is the intrapartum, and then is the antepartum 28 weeks. Okay, three steps for precautions which you have to do in the patients of heart diseases. Number one, NVD is always preferred over cesarean, but you have to give epidural anesthesia. In coarctation of aorta, we cannot do the normal delivery. We always do cesarean, that you should remember, number one thing. And number two is that whenever we are doing the normal delivery, we have to give the patient painless normal delivery, that is by epidural analgesia. Okay, so first stage, in the first stage we have to give the patient antibiotic prophylaxis. As I already told you, the most commonly rheumatic heart disease is there, and we have to save the patient from infection. So in the first stage we have to give antibiotic prophylaxis. In the second stage we have to cut shorten the second stage by applying forceps, outlet forceps. Okay, we have to cut short the second stage by applying the forceps. And the third stage, we have not to give ergometrin, because ergometrin increases the cardiac output a lot, so patient can go into heart failure. So no ergometrin in the third stage, that is methyl ergometrin. And the fourth stage is, now usually the fourth stage is of 1 hour, but in this condition the fourth stage will be of 1 day. Okay, fourth stage is of 1 day. Okay, next is thyroid diseases in pregnancy. Okay, uh, uh, it can also be asked, because they are last in the last FMG exam they have asked about hyperthyroidism drug, so it can be asked. So that is why I give a very short note here. So first of all, there is hypothyroidism and hyperthyroidism both. So HCG, which is secreted during the early pregnancy, seems has is much same in structure like TSH. So thyroid gland gets stimulated due to the HCG. When the thyroid gland gets stimulated to the HCG, it start secreting more T3 and T4. So due to balance all that, the TSH decreases and T3 T4 increases. Now this is the total T3 T4. Okay, so the normal, because we have studied that it is a normal thing that in the pregnancy TSH decreases and the total T3 T4 increases. So the normal TSH value is 3. Okay, in a non-pregnant patient like me, it is the value is around 5, but in the pregnant patient the normal value for the TSH is 3. Okay, in the pregnancy, the another physiological change is that globulin increases, right? And albumin globulin ratio also changes, right? So globulin increases in pregnancy. How I remember globulin increases कि गोलू गोलू बच्चे आते हैं ना, तो ग्लोबुलिन का मतलब इंक्रीज हो जाता है. ठीक है, सो ग्लोबुलिन इंक्रीजेस इन प्रेगनेंसी. सो थायरोग्लोबिन ऑल्सो इंक्रीजेस. As thyroglobin increases, what is thyroglobin? T3 T4 binding protein. So the increased T3 T4, they bind with the thyroglobin, increased thyroglobin in. So the free T3 T4, they are same. Okay, only the TSH value is changed. T3 T4 they get increased, but they are not increased in the lab values, because lab values they estimate free 3T and free T3 and T4. So the free T3 T4 are same, as due to the increased thyroglobin, more T3 and T4 bind to the thyroglobin. I hope you are clear with this fact. Now let's go to the next slide. Now if TSH is more than 2.5, then we have to check for the TPO antibodies. If TPO antibodies are increased, then there are increased maternal and fetal complication. If we go in the maternal complication, then the mother suffers from preeclampsia, preeclampsia, and APH and threatened abortion, all this complication occur. If we go in the fetal complication, then neurological and behavioral problems are there. Okay, so treatment, if is the patient gets hypothyroidism in the pregnancy, we have to give tablet thyroxine 100 microgram. If it's new onset hypothyroidism, if it's old onset, we have to increase the dose by 30 to 40% dose as the thyroid uh, demands increases. Okay, what is hyperthyroidism? If the TSH decreases less than 0.1, it means that the patient is suffering from hyperthyroidism. The management is that we have not to exactly treat the hyperthyroidism, because as whatever drug we will give to the mother will also act on fetus. Okay, and fetus is much more sensitive. Okay, and congenital anomaly can occur if the thyroid is over treated, if the patient goes into hypothyroidism by over treatment of the hyperthyroidism, so congenital anomalies can occur. So we always leave slight hyperthyroidism left untreated. Okay, methimazole and carbimazole, they are contraindicated in the pregnancy as they are teratogenic. Okay, propyl thiouracil is safe. Methimazole and carbimazole, they cause guanal atresia and aplasia cutis. Okay, so that was all about the important things about the medical infections and the medical diseases in the pregnancy. Okay, I don't expect more than this in your exam, so that's why I give such a limited knowledge. I hope you like the video. Do subscribe, share, and like my channel. It encourages me a lot and helps in my teaching journey. See you soon in the next video. Till then, good day.